This is a lecture for Adler Graduate School course number 771, Creating and Assessing the Therapeutic Alliance. In this lecture, I present some history of the evolution of thought about the therapeutic relationship and the variety of ways various theorists have described the ideal relationship between therapist and client, as well as a summary of some of the research that has been done on the therapeutic relationship. The focus on relationship means that we are almost exclusively dealing with the interpersonal process that occurs between client and therapist, although a related topic, how much to talk about the relationship in therapy, is also considered. Some models of therapy advocate a focus on the relationship only when an impasse has been reached in the course of the therapy, while other models emphasize the healing and curative powers of a positive relationship and are focused on it throughout the therapy. Another key distinction between the various perspectives on the therapeutic relationship is the level of analysis. At the individual level, the focus is on personality attributes of the client, the therapist, or both that are contributing to the relationship. There can also be an interactional level of analysis in which one person's attributes and actions serve as a trigger or an invitation for the reactions of the other. Some models emphasize the therapist's impact on the client, while others emphasize the client's impact on the therapist. A third type of interactional analysis is the more circular, positing that each party is both acting and reacting to the actions of the other as the relationship progresses. Early in psychoanalysis, treatment and the therapist were conceived of as a blank screen onto which the client projected their fantasies and wishes, which were then interpreted by the therapist. Client feelings about the therapist were transferred from the childhood relationships of the client. Interpretation was the curative factor. Any feelings that the therapist had about the client were discussed as countertransference, reflections of unresolved psychic conflicts in the therapist, and these were referred back to the therapist's therapy. In Richard Sturba's 1934 article, The Fate of the Ego in Analytic Therapy, he maintained this individual and unidirectional level of analysis, while theorizing that there was an ego-observing process in the client that alternates with the transferential process, and suggests that interpretations target the transferential processes. In 1956, Elizabeth Zetzel wrote an article that expanded the concept of the ego-observing process and used the phrase therapeutic alliance to describe a relationship that included empathy and support as curative elements in addition to interpretation. Ralph Greenson was a psychiatrist in Los Angeles, perhaps most famous for being Marilyn Monroe's therapist. He also made significant contributions to the psychoanalytic literature on therapeutic relationship. For example, his 1965 article, The Working Alliance and the Transference Neurosis. He detailed more specifically the client's ability to align with the tasks of therapy in what he called the working alliance. One part of this working alliance was a personal bond between therapist and client that was free of transferential elements and had some curative effects in the therapy. Edward Borden was a counseling psychologist and more affiliated with the humanistic tradition of Carl Rogers, but he worked to integrate these humanistic insights into relationship with the evolving psychoanalytic conceptualization. He adopted Greenson's term, working alliance, and added an emphasis on mutual identification and agreement on the goals of therapy. It is his pan-theoretical conceptualization of the therapeutic relationship that serves as a foundation of the working alliance inventory, which we will be using in this course. As early as 1913, only a couple of years after he left Freud's Psychoanalytic Society, Alfred Adler was defining a therapeutic relationship that was markedly different from his former colleagues. In an early paper on therapeutic relationship and therapeutic technique, he wrote, quote, "A basic principle for the therapist is never to allow the patient to force upon him a superior role." End quote. He was quite explicit about the task of therapy as giving the client the experience of contact with a fellow man, and thus awakening their social interest. He saw this as analogous to a parental role in the development of the client, noting, quote, "If the mother fails in this, the task is likely to fall much later to the physician." This relationship is characterized by equality, encouragement, and mutual respect. Another early individual psychology therapist, Erwin Wexberg, wrote an excellent book on psychotherapeutic technique titled Individual Psychological Treatment, in which he describes an active and engaged style of relating to the client. This book also makes it clear that the individual psychology therapist views educating the client about their lifestyle as a primary change agent instead of the insight that is characteristic of the psychoanalytic tradition. Rudolf Dreikurs produced the most definitive statement on the relationship. I quote his definition on pages 171 and 172 of my paper on misalliance movements. And now, I notice that I had an incorrect page number in my paper. The quote is actually on page 65 of Dreikurs' collected papers, not on page 7. I think his conceptualization of resistance as a discrepancy between the goals of the therapist and those of the client profoundly defines the nature of the therapeutic relationship in individual psychology. Dreikurs also makes it clear that the interpersonal process between therapist and client and the awakening and nurturing of social interest in the client are important components of therapy. This course approaches the therapeutic relationship from 4 interrelated perspectives: informed consent, bond, task, and goal. Informed consent defines the therapeutic relationship as a contractual relationship and is a foundation process for a respectful relationship. The other 3 perspectives, bond, task, and goal, are adapted from the work of Borden on Working Alliance and the Working Alliance Inventory, which is a 36-item assessment instrument we will be using in this course. Let's get acquainted with the Working Alliance Inventory and then continue our exploration of the literature on therapeutic relationship. The Working Alliance Inventory is a 36-item assessment instrument designed to operationalize Borden's pan-theoretical conceptualization of the Working Alliance. You will be reading the most recent version of the manual in the next unit. It is made up of 3 factors: bond, task, and goal. Because different perspectives can have different views of a relationship, there are 3 different forms available: one for an observer of the therapeutic relationship, one for the client in the relationship, and one for the therapist in the relationship. One form or the other, sometimes 2 forms, and occasionally all 3 forms, are widely used in the research on therapeutic relationship, and there is an annotated bibliography of some of this research available on the course page. Research has found that client and observer ratings of alliance have a similar and strong relationship to outcome, whereas the therapist rating of alliance is less powerful in predicting outcome. This is extremely important to keep in mind as you work with clients. Just because you feel like you understand the client does not mean that the client feels understood. In this course, the items from this assessment instrument are used to define, measure, and understand the therapeutic relationship. You will be applying these items to your life experience and clinical relationships in a paper for Unit 5, and evaluating the therapeutic relationship of a recorded therapy session with the observer form for your special project at the end of this course. Now, let's look at some of the research on the therapeutic relationship. First, we will look at the client factors that have been found to significantly impact the therapeutic relationship. Then we will look at the therapist factors, and finally, we will look at some interactive factors that have been identified. There are a number of studies that have studied the impact of diagnosis and/or severity of impairment of the client on the therapeutic relationship, and the results have been quite mixed and difficult to replicate. Over a number of studies, a trend for people with personality disorders to have a more difficult time establishing and maintaining a positive therapeutic relationship is evident. There is a whole body of research on the relationship of object relations and attachment style, generally supporting the notion that persons with fearful, anxious, dismissive, and preoccupied styles have a more difficult time establishing and maintaining a therapeutic relationship. There is evidence that the client's view of the therapeutic relationship evolves over time. There is strong evidence that a poor alliance at the end of session 1 is a predictor of early termination and poor outcome. There are also findings that the alliance in sessions 3 to 5 is a consistent predictor of outcome in therapy, oftentimes better than measurements that are done in the middle or toward the end of the course of therapy. Empathy is one of the core conditions of the therapist that Carl Rogers identified, along with unconditional positive regard and congruence of the therapist. To build a good interpersonal bond, the therapist needs to be able to not only accept and appreciate the client's world, but also to individualize the expression of understanding and support to suit the client's relationship stance. Creating a relationship in which the client feels understood is an essential competency for a therapist. That being said, it is also important to note that alliance is a broader concept than empathy, and when assessed independently, alliance makes an additional contribution to predicting positive outcome in therapy. Other therapist factors that have empirical support are an optimistic attitude and the ability to generate hope and open and clear communication. It is easy to see how these factors overlap with one another, and researchers have been very creative in figuring out ways to measure these various aspects. A good therapist has the ability to convey understanding and appreciation of the client's phenomenological perspective, as well as a belief that things can change for the client. Research into the impact of experience and training of the therapist have yielded equivocal findings. There is a fairly consistent negative correlation between alliance and training, but a positive correlation with measures of therapist skill. Training may be a necessary but not sufficient condition for the therapist, particularly with more difficult and disturbed clients. Overall, clients with difficulty forming close relationships have stronger alliances with more experienced therapists, while less relationally handicapped clients do not respond differentially to levels of experience. Several therapist factors have been found to negatively impact outcome. A controlling or take-charge attitude does not seem to work well with most clients. Therapists who are perceived as irritable, cold, or distant by the client tend to have poorer outcomes, as does the offering of interpretation or insight prematurely. Timing in therapy is discussed a great deal, but establishing clear guidelines for good timing has been elusive. There has been a great deal of discussion of the importance of therapist-client match, but little, empirical support for any proposed strategy, and limited evidence for the impact of any identified dimension on outcome. There is evidence that greater complementarity in terms of dominance and control results in a more harmonious verbal transactions between client and therapist through the course of therapy. And this increase in harmonious, positive, moment-to-moment interactions was closely related to a good working alliance and to outcome. This same research found that the opposite was true as well. In other words, similarity in dominance and control styles was associated with more negative interaction and decrease in working alliance. There are also a number of studies to support the idea that psychotherapy outcome appears to be considerably enhanced when client and therapist are actively involved in a cooperative relationship characterized by agreement on therapeutic goals and the processes to achieve these goals. This echoes Rudolf Dreikurs in his emphasis of the importance of alignment of goals in the therapeutic relationship.